Hello, everyone. This is Siddharth Dambar from Chicago Arthritis and Regenerative Medicine. Welcome to our webinar today, Regenerative Medicine Treatments for Runners. Appreciate everyone taking the time today. Things we'll be talking about during today's webinar include the following. You'll learn about the best available treatments for running injuries that do not require surgery, specifically utilizing regenerative medicine treatments, which utilize your own blood and bone marrow stem cells, what is legitimate and not legitimate in the field of regenerative medicine, and how to choose the best physicians, clinics for regenerative medicine, and how to avoid the snake oil sellers. As a reminder, as I'm talking, if you have any questions, please go ahead and enter them into the chat section. I go over most typical frequently asked questions. And however, if there are more specific or other questions, please leave them in the chat and I will try to get to them as I am talking. So big question is, what would you do if your pain was controlled? How would your life improve? What exercises would you restart, and what activities with family and friends would you participate in? So who am I? My name is Siddharth Dambar, physician at Chicago Arthritis and Regenerative Medicine, specialist in rheumatology, also specialist in image-guided musculoskeletal injections, in practice since 2008, and involved in regenerative medicine since 2008, and within the Regenerative Network since 2012. The Regenerative Network is the largest network of independent physicians who are involved in regenerative medicine. So what is the traditional care that runners typically have to deal with when they have problems? A few things. Number one, essentially they stop running. They can use pain medications, brace, wrap, ice, acute injuries, but essentially all things that are just masking the pain and all things that are just waiting for eventual surgery. That's a problem because traditional care, pain medications don't fix the problem. They do mask the problem. They do have a lot of potential side effects, including kidney, stomach, liver, heart, and bleeding issues. Chronic opioids are obviously an epidemic in this country and have their own set of issues that are not very good. The traditional injections that are utilized by most physicians when it comes to orthopedic issues and running issues include steroid injections, which are not great because they can damage tissue, increase the risk of infection, diabetes, and osteoporosis. A very common treatment these days are to utilize nerve blocks and radiofrequency ablation to basically burn off the nerve to kind of reduce pain. The problem with that is that it is actually inducing nerve damage, which can then long-term lead to muscle weakness as well. All problems if you're trying to stay physically active. Additional issues with problems with traditional care. With surgery, certainly higher risk than any kind of injection or needle-based procedure, namely risks of bleeding, infection, tissue damage, anesthesia risk, cardiac risks. The most common minimally invasive surgeries that are done for, let's say, knees and hips, arthroscopic surgeries, do increase the risk of instability. If you have, for example, if you have a meniscus surgery and if you already have even mild arthritis, that's been proven to be no better than just physical therapy alone. It does increase the risk of progression to more arthritis. And the classic issue is that one surgery, minimally invasive, then leads to the next surgery, which is much bigger, an open knee replacement or hip replacement. In reality, for those of us who do this in a significant fashion, we feel that 80% of musculoskeletal conditions can avoid surgery and can be treated with just needle-based procedures alone. So in searching for better options, we're looking for options where you can avoid side effects and that are low risks, treatments that improve the actual cause of the problem, and that can give you a longer term improvement from treatment. So imagine reducing your pain and getting back to the activities you care about without surgery or pain medications. So regenerative medicine is the field of medicine where you're utilizing your body's own cells to treat arthritis, tendinitis, injuries, and back pain. You're essentially utilizing the normal healing process. Essentially, after an injury, to take something as small and limited as a cut to your finger, your body infiltrates that area with platelets and other growth factors. Those cells then instigate a healing process that starts with inflammation and then develops into a progressive cellular healing process that can take days to weeks to even months, depending on the degree of injury. So tissues that have poor blood flow typically do not heal well. That includes tendons, cartilage, ligaments, discs, labrums, and meniscus. Regenerative medicine is a process of injecting those cells that coordinate the normal healing process into tissue that has been damaged in order to recover. So why regenerative medicine? It treats the problem. It's safer than surgery. It's effective for most musculoskeletal conditions. And again, for those of us who do this in any significant degree, strongly feel that 80% of traditional orthopedic surgery will eventually be managed and replaced by regenerative medicine. In the same way that the vast majority of cardiac issues are no longer handled via open cardiac surgery, the vast majority are now handled by needle-based procedures by cardiologists. That's likely where the field of musculoskeletal medicine or orthopedics is headed as well. So how does regenerative medicine work? So a few key things. Number one, when you inject those cells into a damaged joint, tendon, or ligament, you're able to optimize the damaged cellular health of that tissue. You do that because in a damaged joint or tendon, what you find are cells that are no longer biologically acting correctly. They're no longer producing the correct proteins and enzymes that you see in a healthy joint or tendon or ligament. By injecting your own stem cells or platelets into that damaged tissue, you're able to get those cells to start functioning more appropriately and better. In addition, these treatments help to improve strength and stability and support of ligaments, tendons, and other soft tissue structures. By strengthening those supportive structures that are weakened, you then are able to help with not only function, but pain as well. Stability helps with pain and function. In addition, these treatments do reduce chronic inflammation. Even though they incite inflammation up front, they reduce inflammation longer term. And lastly, you can also improve the neuromuscular health of a joint or tendon or ligament. Essentially, you have nerves that get irritated with pain over time. We're able to treat those either by treating a compressed nerve or by strengthening the muscles and other neuromuscular tissue that have been chronically damaged as well. So a few key things to note. Some very kind of bare basics. Is this legal? And the answer is yes. So there have been physicians practicing regenerative medicine realistically since really the early 90s, but really more significantly in the last 15 years. And since that time, the FDA has progressively given us guidance in terms of what is appropriate and what is legal and what's considered safe in the United States. So we know that here's what is legal. Utilizing your own cells is legal. You need to use cells that have not been significantly altered or adjusted or manipulated, and you need to inject them into damaged orthopedic tissue. I'm strictly talking about treating orthopedic conditions. If you're interested in treating things like heart, kidney, lungs, COVID, this is not the lecture for that. This is really treating more arthritis, tendinitis, injuries, and back pain. Second question I hear a lot is, if I'm older, shouldn't I use someone else's cells? And the answer to that is no. For the vast majority of orthopedic conditions, there's good evidence that utilizing your own living cells is effective. Note that there are potential risks if you're utilizing someone else's own live cells. For example, there's a risk of possibly transmitting someone else's disease or other kind of genetic issues. And there's also the risk of potential rejection, where your own body does not respect or recognize those foreign cells and can actually reject that. Note that when it comes to injecting your own live stem cells, there's very few exceptions where that is legal. You can utilize that for childhood leukemias. It's relatively limited for really any other condition at this time. Is there an age limit? Short answer is no. The results that we see for knees, lower back, shoulders, elbows, ankles, and neck are not impacted by age. Hip outcomes, hip arthritis outcomes are, however, impacted by age. What kind of doctors are typically performing these treatments? I really think it should be a physician who's focused on musculoskeletal conditions. Should not be a doctor who is doing Botox on the side or doing a liposuction on the side and then is kind of jumping in to treat your knee or your ankle or your back. That doesn't make sense. That's not how medicine works. You really should be focused on what you're doing. Should be a physician who's focused on non-surgical treatments for orthopedic conditions. While orthopedic surgeons have significant experience treating musculoskeletal conditions, they look at it from a different perspective. When you look at it from a surgical perspective, it's different. It essentially is looking at tissue and seeing pathologic tissue with an understanding that you should cut it out or replace it with some other kind of hardware, metal or plastic hardware. That's different than how a regenerative medicine expert looks at this, where we're really trying to optimize your existing tissue. It's a very different kind of way of looking at this. Next, can these treatments help if I've already had surgery? And the answer is yes, unless you've had a joint replaced. So if you've had, let's say, an arthroscopic knee surgery or an arthroscopic hip surgery, there's definitely evidence that these treatments can help after treatment if needed. In fact, what you'll find amongst your highest level professional athletes in this country is that even after they've had a traditional orthopedic surgery, frequently they will have some kind of cellular treatment applied at the same time to help bolster or improve their outcome. And certainly we see that in the general population as well. My general rules I recommend people for orthopedic surgeries is, if possible, try to keep your own anatomy, avoid surgeries that are strictly cutting out tissue. Always consider regenerative medicine treatment option if you have been recommended surgery as well. So some really key concepts in regenerative medicine I'm going to touch on, which I think will help explain how it is that we're treating running issues. So stability or prolotherapy, orthobiologics, and interventional orthopedics. I'll explain each one of these. So stability is really key when it comes to your musculoskeletal system. Biotensegrity is this concept that the overall functional strength of a structure is stronger than the individual units. So what that means is if you take the individual units around the joint and if you put them into compression and tightly close to each other, they'll offer more stability than you would expect than the individual units on their own. It's important because when you have one injury, it leaves that overall structure weaker. If you have a severe enough injury or long enough injury or chronic enough of an injury, that whole structure can become chronically unstable, which can then cause progressively more and more stress on the other parts of the structure. So a classic example would be somebody who is, let's say, a runner or any other kind of physical activity and develops a mild strain of their knee at one time. That mild strain might be, let's say, medial collateral ligament, mild injury. You can then look at that years later, and you'll find that there's been slight instability in that knee ongoing for years, which then has progressively led to more stress in the meniscus, the cartilage, the other kind of tendons, and other ligaments in the knee as well, and has now led to a progressive degenerative process. Prolotherapy is the process of injecting your own cells into those soft tissue areas to offer more support and improve structural support and to strengthen and stabilize that area that's been injured and to provide more support and stability for the overall unit. The key here is to understand that there's layers and depth to treatment, meaning when you look at something like a knee, understand that even if you have a degenerative process in one compartment of the joint, there's layers of tissue on top of that that have been impacted that are also being stressed and leading to that instability and degeneration. And so the key to treatment is to treat not only, let's say, the joint that's been injured, but the support of ligaments, meniscus, tendons, other soft tissue structures around there as well to strengthen them, which will then give you a better outcome long term. These treatments take time. That progressive strengthening will take months over time to really get better. It's important to understand that it doesn't happen quickly. And also understand that these kind of treatments do give longer lasting results than your typical steroid injections do. So as an example, when it comes to, let's say, a runner, you need to be thinking about really multiple levels: the lower back, the hip, the knee, the ankle, and the foot. So if somebody presents with, let's say, a knee issue, it's not enough to only think about the knee. You want to also be thinking about what's going on at the ankle, what's going on at the foot, what's going on at the lower back as well. You want to really be thinking about all of those structures, because it's all of that that ends up leading to instability. And if you only look at the knee and you don't address those other issues, you're not going to get a good enough outcome in someone. So this is an example of what I mean by that. So this is a iliotibial band case. It's a 55-year-old man who had right hip pain. He is an active runner. He was told that he has iliotibial band syndrome. That's a common thing that you hear a lot of people talk about, and they'll spend hours rolling out the iliotibial band on the side of their leg, trying to work out some of that muscular tenderness. So based on his exam, which then led to an MRI, what he really has is a pinched nerve in his back that then led to weakness in the gluteus medius muscle on the side of the hip, which then led to an overcompensation by the ITBand. And so the way to treat that is not just by addressing the ITBand, but by really treating the source of the problem. So in this case, the pictures that you'll see here, this is an MRI picture. This is that L4, L5 level, and that's a disc protrusion that's compressing on the nerve. He had PRP treatment where we injected his own platelet growth factors, platelet lysate, into the epidural space. We also treated the ligaments as well. And the response that he had was quite good. So he essentially has had 80% improvement. His ITBand symptoms are improved after we treated his back, and he's back to his normal mileage when it comes to running. To give you a sense of not only clinical improvement, but again, here's that disc protrusion, nerve compression, and here is what it is several months after treatment as well, where that prior kind of protrusion has completely resolved, and now there's a nice sort of that stenosis that it kind of developed has now cleared up as well. OrthoBiologics. So OrthoBiologics are the next key thing to understand. So OrthoBiologics are essentially the biologic cells and tissues that are injected into damaged orthopedic tissue. Again, these utilize the body's normal healing cascade. You can use your own cells or someone else's, and I'll discuss briefly why you should really be using primarily your own cells. So platelets or platelet-rich plasma is really the first and most prominent orthobiologic treatment that we utilize. After an injury, platelets recruit other cells and growth factors to assist in repair. They utilize focused inflammation to help repair tissue damage. Platelet-derived growth factors stimulate local mesenchymal stem cells. That's another way that they're actually able to help with repair. Your mesenchymal stem cells are the main chief driver of recovery from an injury. Those growth factors from platelets help to stimulate them. So there's two different types of platelet products. There's platelet-rich plasma and platelet lysate. Essentially, with both of these, you do a blood draw, you centrifuge this down, you concentrate it into the concentration that you want, and then you inject that into a tissue that needs to be treated. So platelet-rich plasma is a very high concentration of platelets, very helpful if you need to treat joints or tendons. Platelet lysate is essentially taking those same platelets, cracking them open, and just taking the growth factors. It's less inflammatory. It's a better option when you're treating nerves as well as ligaments. Most physicians who do this do not have a great deal of flexibility in terms of how they prep this kind of product. So the picture that I have on the right, on the left side, you've got platelet-rich plasma without red blood cells. That's the yellow-colored one, orange-colored one. And then on the right side, you've got platelet-rich plasma with red blood cells. The one on the left is safer and better when you're talking about joints and tendons. And the one on the right is what you would use for muscle-related issues. Your physician should have that flexibility. Most physicians do not. They look at it as a one-size-fits-all process. That's a problem because realistically, none of us are one-size-fits-all. And I would definitely recommend having that kind of flexibility by your physician when it comes to treatment, meaning specifically tailoring it to what your issue is. So this is a case study of a gentleman who's a 45-year-old triathlete. He has he'd been referred to me by his sports medicine physician. He has patellar tendinitis. And he had persistent pains despite physical therapy, rest, and activity modification. So this is her patellar tendon. This white structure here is the patella or the kneecap. This structure here is the patellar tendon. Over here is some bone spurring. This overall patellar tendon is pathologic and is what's causing her pain. So she ended up having 2 platelet-rich plasma treatments over the course of roughly 3 months or so. This is an example of that. That's the needle right here, injecting into the tendon, which is right here, and very precisely injecting that into where the tendon's been damaged. She had a very good response, was able to get back to her normal and full activities. 3 years later, she presented again, now with a right knee hamstring strain, and again, treated that with PRP, pain resolved, and is again back to activity. That's the kind of outcome we're looking for, which is pain relief, functional improvement, and back to normal life and activity. Stem cells are the other big type of orthobiologic treatment you'll hear about. So they are the main cell line that helps to recover and repair after an injury. Again, there's a concept of utilizing your own cells or using somebody else's cells. In the United States, the only live stem cells that you can utilize are utilizing your own cells. And I'll talk about that in the next slide. So bone marrow-derived stem cells, which means coming from your own iliac crest or the back of the pelvic bone, that is legal in the United States. There's data on the effectiveness of bone marrow-derived stem cells that goes back to the early to mid-90s. Fat stem cells, which have been relatively popular over the last 10 years, worldwide are considered illegal in the United States because of the type of enzyme that's utilized to dissolve some of the connective tissue in the fat. You can, however, use fat or adipose for structural support for orthopedic conditions, but as a strictly speaking stem cell treatment, that is not a valid or legal entity in the US currently. You've probably heard a lot about umbilical cord or amniotic stem cells. Understand that these are unfortunately being described as a safer and better option for older patients, but that is not accurate. Physicians who are saying that are either mistaken or misguiding. Essentially, the way that these cells have to be prepped in the United States is as follows. After birth, the tissue is collected, the amniotic or umbilical cord. They are then gamma irradiated and freeze dried and essentially pulverized into a powdered form. That powdered form is then put into a vial and shipped to the physician's office, where it can then sit for 18 to 24 months, after which time, or at which time, they can then be rehydrated by injecting water back into them and then re-injected into the patient. Understand that there's no live cells in that. Three different groups have looked at this in significant fashion. There's no live stem cells in these products across the board. They do have growth factors, which likely helps, but they're not an actual stem cell product. They're being, unfortunately, marketed as such, and that's really unfortunate and disingenuous. You probably get a similar effect as you would from just using your own platelets, but the benefit of using your own platelets is that it's your own cells, and there's no issue with utilizing contaminated someone else's cells that you do with these amniotic or umbilical cord cell products. The other one you may have heard of is IV stem cells. That you probably don't really hear too much of in this country, but you do in other countries. There's no proven benefit for orthopedic conditions. Again, they may help with some other things like heart and lungs or COVID, but that's obviously not what we're talking about here. Stem cell treatment outcomes. So our main outcomes are based on improving pain and function, frequently even in advanced cases. We can help in advanced cases, including advanced knee arthritis, because you can improve stability, improve inflammation. You can get cells that have been damaged and chronically dysfunctional and get them to start working better, makes the joint biologically more healthy and functional. You can also improve exercise tolerance. And as an individual has better activity and exercise tolerance, it helps with strength and support of the treated area as well. Can you improve X-ray and MRI images? I'll show you a couple images in a moment. For advanced arthritis, the answer is no. For tendon tears that are less than 2 centimeters, the answer is yes. For ligament tears, yes. If you've got swelling in the bone from an arthritic joint, the answer is yes. And if you have what's called avascular necrosis at an early or moderate stage, that can be helped as well. So this is a nice example of a relatively young man, 28-year-old man who's a runner. He had an ACL tear, essentially had treatment relatively soon thereafter. And 3 months later, he had a really good response. He's had significant functional improvement and was able to get back into really dynamic physical activity. So can you treat ligament or tendon tears? And the answer is for partial thickness tears. That means where the tendon or the ligament is still closely approximated. The answer is definitely. If it's a full thickness tear, as long as it's not separated apart or pulled apart, yes, you can still treat that. So this is an example of an ACL injection under X-ray guidance. So over here, that's the patella, then the kneecap. This is the thigh bone, the femur. This is the tibia, the shin bone. This is the needle that's headed into the knee joint. And essentially this is injecting into the knee and injecting into the ACL. And what you see basically kind of blacked out, that is the ACL. That's how we confirm we're in the ACL ligament. It's a relatively precise and targeted injection. And the response for him was quite good. So this is his knee pre-treatment. This is the ACL. It's extremely disorganized. It doesn't look like a straight line at all. It's actually likely a full thickness tear, just where the ligament is not retracted. This is 3 months later. This is really what a normal ACL looks like. That's really quite nice looking, very linear, straight. There's a little bit of fluid still there, just indicative of that prior treatment. But really, that's exactly what we're looking for. And he's had a great response from treatment. So here's a great question. Is running bad for the knee? Number one, we know that running has tremendous health benefits for most people, either in terms of maintaining close to ideal body weight, muscle strength. Note that for some runners, the knees can take on too much stress. But for many runners, their body adapts. There's neuromuscular adaptation and there's cartilage conditioning. So how do we know this? Well, so there have been a couple studies that have looked at this. There's a study from 2013 that found that in people who were able to maintain running into their 60 plus years, that their chance of having knee arthritis was very low compared to folks who were not able to run. Now that might make sense in the sense that, well, you selected someone who can actually survive their running. But another interesting kind of look at that, a recent study looked at, given the amount of force that's put on a knee with running, the vast majority of people who've been running for decades should have arthritis. And yet, many of these people do not because their body and their knee is able to cope and compensate. So if your body's able to cope and compensate and you don't have pain, then you should continue to run. I think signs that would indicate that you should get evaluated would include if you had pain either in the beginning or during running or after running, if you have swelling for sure, or if you have knee instability. And knee instability can be if you have a locking sensation, if you have a looseness to the knee where you feel like it's giving out, or even if that one knee, you find that it has some instability findings, and that would include like, the knee feels a little bit more fatigued than the other side does. It may not be a muscular issue, it may be a ligamentous instability issue. All of those are things that can be evaluated and treated. So another really great question is, can we treat bone-on-bone arthritis? And the answer is yes. Knees are an incredibly hardy and biologically sound joint. And we know that arthritis is a biologic condition and it's treatable with orthobiologic treatments. If your range of motion is relatively intact, if the function is still intact, good outcomes are still possible, especially for knees. Knees tend to respond very well to treatment, even in people that are older or even in people that have more advanced arthritis. Some caveat to the bone-on-bone arthritis issue. If you've got advanced hip arthritis, that is a very hard thing to treat. Generally, hip surgery would be advocated, or hip replacement surgery. And then also keep in mind that our expectations, if you have more advanced arthritis, it's not about improving how the x-ray looks, it's really about improving pain and function. Interventional orthopedics. So interventional orthopedics is this concept where under x-ray and ultrasound guidance, we're able to inject very precisely orthopedic tissue that has been damaged. That's something that is really not possible when you're doing this just by feeling the surface structures or doing it blindly. I have colleagues who tend to be a bit more experienced and older who claim that they can hit these structures without actually utilizing ultrasound or x-ray guidance. I do not have x-ray vision, and so I continue to use the tools that I have, and that includes x-ray and ultrasound guidance. These are some pictures that I showed before, but it's an example of where we injected under really fine ultrasound guidance into somebody's patellar tendon. This is, again, utilizing X-ray guidance as we're injecting into someone's ACL. All things that you really can't do with any precision if you're doing this without X-ray and ultrasound guidance. So image guidance is really a necessity. It's another example of where image guidance comes in handy. This is an individual that has avascular necrosis. Avascular necrosis is a condition where the blood supply to the bone has been damaged, and that can then lead to not only pain, it can also lead to degradation of the bone, functional limitations, a lot of other problems. So this is a 41-year-old man who had left ankle pain. He had some degree of osteoarthritis, chronic inflammation, but really what he had was avascular necrosis. So we ended up injecting his own stem cells into the joint as well as into the bone. And really 3 months afterwards, he's had a great clinical response. He's also had a great imaging response as well. So here's what I mean by that. So this is this individual's ankle, and this is where the avascular necrosis is. That's where the bone is basically dying. We injected directly into the bone and into the joint. And this is basically his image a few months later. That swelling the bone is gone, inflammation of the joint is gone, and again, pain relief. That's the big thing here. So he's had a great response and is back to his normal physical activity and is also back to his normal work activity, both of which require significant standing and stress on the knee. Regenerative medicine treatments offer safe and effective solutions for your pain. So a couple other things. Is this too good to be true? So there's evidence from Philip Hernigue. He's an orthopedic physician from France. He's been treating knees and shoulders in particular since the 1990s. He has studies that actually even compare treating one knee with someone's own bone marrow-derived stem cells and the other knee with knee replacement. He has examples where he's treated one joint, let's say one shoulder, with just surgery, and then the other shoulder with just his own bone marrow. And in some cases, treating one shoulder with just traditional surgery, and then the other shoulder with traditional surgery and utilizing his own bone marrow combined. So there's data that really goes back quite a far way there. The Regenix Network has data that goes back since 2005. My own personal experience dates back to 2008. While this is a rapidly developing field, it's not new. If you have physicians that say there's not enough evidence or data on this, they likely are not aware of the evidence or data. It's important to understand the difference between a specialized and expert opinion versus an opinion that may be shooting from the hip and that may be inexperienced in that realm. Also keep in mind that there's right and wrong ways to do this. And that's important because if you're doing this the wrong way, you're not going to get the right kind of results. If you do it the right way, then you put the odds into your favor. And of course, your expectations should be grounded in reality and evidence-based medicine. How long do results last? Regenix has data that goes up to 10 years. Philip Hernigue has data that goes up to 15 to 20 years. What I tell people is if you have a chronic condition, expect a repeat treatment at some point. That may be a couple of years down the line. So we have is that if someone has had a good response from one treatment, a second treatment will give them an additional response above that. If you have more of an acute condition, let's say an acute soft tissue injury, that's something that may only take one treatment, and you may be fine long-term if you're catching it at an early stage. Best way to maintain results after treatment, improve your biomechanics, working with physical therapy, take the appropriate joint healthy supplements, and repeat treatment, understand, is additive to the initial treatment as well. Cost, always an important question. Not routinely covered by insurance. So the options for insurance coverage are as follows. RegenixCorporate.com, that's Regenix. They have gone through the process of talking with various self-insured companies. That's pretty much all large companies. And they've gone through the process of talking with probably around 50 of them to get this under coverage added to their benefits plan. So that is definitely a possibility. You just have to go through the process with that. Medicare has a experimental code for platelet-rich plasma. TRICARE, which is the military government insurance, is currently covering platelet-rich plasma for elbow tendinitis and knee osteoarthritis. So we'll likely see coverage for platelet-rich plasma in the next couple of years. I think bone marrow-derived stem cells will take longer. Cost estimates in the US, this is sort of averages. For platelet-rich plasma, generally about $1,500 starting point, and for your own bone marrow-derived stem cells, $6,500. Keys to determine value: number one, make sure your physician and clinic are appropriate experts in the field that they're trying to treat. Number two, make sure you're getting a real stem cell treatment, not something that's being mislabeled, a amniotic or umbilical cord product, which is mislabeled as a stem cell treatment. And then lastly is understand that these are in-office procedures. You don't require hospitalization or a surgery center to do this, which typically drive up facility fees as well. So here at Chicago Arthritis and Regenerative Medicine, our general approach is we're focused on non-surgical treatments for your arthritis, tendinitis, injuries, and back pain. We look to evaluate for inflammation, instability, asymmetry, and neuromuscular issues. Try to correct these with low-risk interventions if possible, including exercise, physical therapy, and supplements. If not working, then recommend regenerative medicine treatments. Trying to use the best treatment options, products from your own body, the same things I would recommend to my own family and that I use for my own family. Giving you a plan that is specifically tailored for your condition and your needs, and delivering those cells using the highest level of imaging guidance possible. How do you get evaluated? So if you're watching this on the webinar, you'll see on your screen popping up a relatively simple way to book a evaluation or appointment where you can schedule based on your convenience of your time, either in office or telehealth. Currently, we're trying to do most things via telehealth, given the current medical situation in the public health sphere, but we are available to help out in any way possible. Well, I appreciate everyone's time today. If there are any other questions, please put them up on chat, or if there's anything that I have not answered, please go ahead and put that up on chat at this time. I'll give that maybe a minute. And if there's nothing else, I'll go ahead and close it out. But maybe I'll give it another minute to see if anyone else has any other questions that they want to put up on chat at this time. Great. Well, I don't think we have any other questions. So thank you, everyone, for your time. Appreciate it. If there's any other way that I or my office can assist with questions, evaluation, treatment, understand that we're available here to assist in any way possible. And until we reconnect in the future, hope everyone has a good day. Stay safe, stay well, and live well. Bye-bye.